Welcome to Pharmacology Lectures. Now we are continuing neuromuscular blocking agent. Now neuromuscular blocking agent means they block the transmission between motor nerve endings and the nicotinic receptors on the skeletal muscles. Now they possess similarities to the acetylcholine and act either as antagonist, non-depolarizing, or agonist, depolarizing. You have to remember this on NMJ. Now blockers are facilitated intubation, rapid intubation when it is needed when you have a respiratory failure, endotracheal intubation, and provide complete muscle relaxation at the lower anesthetic doses. Okay, this increases the safety of anesthesia by allowing the patients to recover quickly and completely. These are used in ICUs. Now, non-depolarizing competitive blockers. The first was curare, the development of tubercularine, followed by cistracurium, mevacurium, pancuronium, rocuronium, and vicuronium. Now its mechanism of action. First we will understand the mechanism of action. Its mechanism is dose dependent. Now at low doses what happens? It will block acetylcholine at nicotinic receptor. Okay, nicotinic receptor, the acetylcholine is blocked. Rocuronium, it comes and binds, and the acetylcholine binding is being blocked. Now it prevents depolarization of the muscle and inhibits muscle contraction. Now competitive action can be overcome by administration of cholinesterase inhibitors, physostigmine or edorphonium. It will increase the concentration of acetylcholine at neuromuscular junction. So this strategy shortens the duration of this neuromuscular blockade. In addition, low doses, the muscle responds to direct electrical stimulation from a peripheral nerve stimulator to varying degrees. Now at high doses, what happens at high doses? High doses, it will block the ion channels. This will lead to weakening of the transmission and reducing the ability of the enzyme inhibitors, cholinesterase inhibitors, which reverses the action. Now what are its actions? We have seen mechanism of action. Now what are its actions? Now due to sensitivity of blockade by competitive agent, small rapidly contracting muscle of the face and eye are most susceptible and paralyzed first, followed by finger, limb, neck, and trunk muscles. Now what is the pharmacokinetic? Two or more quaternary amines. Penetration through membranes is poor, they do not cross BBB, and cistracurium undergoes organ independent metabolism, Hoffman elimination, and verocurium and rocurium are deacylated in the liver, metabolized in the liver and changed in the bile. Mevacurium is eliminated by plasma cholinesterase. Now you can see here the pharmacokinetics. Neuromuscular blockers are minimally absorbed when given orally, so they are given IV. Vicuronium and rocuronium and metabolites appear mainly in bile. Okay, this is kinetics. Pancuronium is excreted primarily in urine. Now this is also about its characteristic features. Okay, here. Now this is the time to maximal blockade, and this is the time to recover. 2 and 40 minutes, 2 minutes and 40 minutes for atracurium. For cistracurium, 3 minutes and 90 minutes. For pancuronium, 3 minutes and 66 minutes. Time to recover 25% of maximal response. Now cistracurium spontaneously degrades in plasma. Okay, it is often used in patients with multi-system organ failure because its metabolism is independent of hepatic metabolism or renal function. Okay, if you have multi-system organ failure, it means hepatic and renal function will be affected, so we can use cistracurium in ventilation patients who are in ventilator. Pancuronium is vagolytic and increases the heart rate. Now, vicuronium, succinylcholine, it is used in post-operative muscle pain, hyperkalemia, and increased IOP and intragastric pressure may occur. Drug may trigger malignant hyperthermia. Now, it has rapid onset of action, therefore, it is used for tracheal intubation for gastric contents. Okay, now adverse effects. These are safe, minimal side effects. Drug interactions with inhibitors. Now, since they are enzyme dependent, so cholinesterase inhibitors, those who inhibit the enzyme. Now, neostigmine, physostigmine, pyridostigmine, and dorfonium can overcome the action of NMBs. With increased doses, this can cause depolarizing block due to elevated acetylcholine. Halogenated hydrocarbon anesthetics. The other anesthetic which are halogenated hydrocarbons such as desflurane, they act to enhance neuromuscular blockade by exerting a stabilizing action at MJ. These agents sensitize this to NMBs. Now, aminoglycoside antibiotics, gentamicin and tobramycin, they will inhibit acetylcholine release from cholinergic nerves by competing with calcium ions, though they will increase its blockade. Calcium channel blocker will also increase the blockade.